Hello, my name is Heidi Engel. I'm a physical therapist at UCSF Medical Center. I've been a physical therapist for 33 years, working in every aspect of acute care, home care, rehab care in skilled nursing facilities, acute rehabs. I have been to all the various settings, but I've spent the previous 10 years full-time in our medical ICU, and I'm now a collaborative member of our COVID-19 treatment team. So I hope this presentation is helpful to you in treating the patients where you are, but also to your understanding of COVID-19 as a public health problem. So this is not a medical problem. This is not a single diagnostic entity. This is really a pandemic. It's a global public health problem. And so what I've tried to do in this presentation is to present the individual patient struggles we will encounter and potential solutions, because we are learning as we go. This is all new, this is all novel, and I cannot pretend to be an expert in something that is still so new and novel for everyone everywhere. At the same time, I think we need to look beyond individual treatment strategies and recall first and foremost that this is a public health problem, and the only solution to help us out of it and to prevent unnecessary deaths everywhere will be for us to understand the public health implications of everything that we do and that we offer. So I want to look at this public health problem divide it into 4 phases of care, which I think can be applied to our individual patients, but can also be looked at the various points in time where we are for the pandemic as a whole. And my hope with this presentation is that there is enough information contained within these slides to help you customize it for your individuals that you'll be treating, customize it for your institution, combined with some of the handouts I'm providing, and also customize it into educational materials for your colleagues and for your patients. So the 4 phases of care as I see them are prevention, sustainability, resilience, and restoration. And then I think you can subdivide each of those 4 components, 4 phases of care, into how do we apply that to patients, how do we look at that for providers, and what does that mean for how we look at our community at large. So let's start with number 1, which is prevention for our patients, and this is where we get into a little bit of the understanding of the pathophysiology of COVID-19. So really, for early detection and management of symptoms, our number 1 goal is do no harm. There are such a spectrum of presentations, as we know, for COVID-19, and it has a variable and somewhat long initial incubation period. The median time is 5 days, but it can be up to 14 days. And people are initially asymptomatic while they are also rather contagious and viral shedding. And so what that means is it spreads easily and quickly. We understand that the most prevalent signs are fever, cough, fatigue, diarrhea, headache, lack of taste and smell, dyspnea. We know that from lab values you'll see lymphopenia, and we know that the virus enters cells through the ACE2 receptor, and it is this downregulation of the ACE2 enzyme receptor that triggers immune responses, that damages the integrity of the epithelial lining of the alveoli, as well as creates entry for the virus into various organ systems. The majority of cases are either asymptomatic or mild to moderate with the symptoms described above, and that accounts for really about 80% of the cases. So 80% will have the shorter contagious period while they are also asymptomatic to moderately symptomatic with viral symptoms. And they're just contagious for less long of a period of time, those cases. 10 to 15% will have a longer contagious period and severe symptoms that can become a crisis after the initial 5-day incubation period, or it can be a later sudden crisis can occur symptomatically when the patients have an exuberant immune response and a large inflammatory reaction to the virus entering their organ systems. Some of the symptoms to watch out for in terms of someone converting into a more severe form of the disease: dyspnea, which would be a respiratory rate greater than 30, oxygen saturation below 93, tachycardia, heart rate above 100. And we know that this can convert to an interesting form of silent hypoxemia, which can then become acute respiratory distress syndrome. There are a number of risk factors that make people more prone to a severe presentation of the disease. Hypertension is the most common of those, but certainly there's also diabetes, obesity, a history of a cancer diagnosis, among a few others. Only approximately 5% end up in the category of having the longest contagious period and becoming actually critically ill. This conversion to critical illness version of COVID-19 can actually take a week to 10 days before it manifests in symptoms that severe. And these symptoms can be presented very suddenly in the patients. And I think one of the most interesting aspects of this illness is that it is so variable and so unpredictable, and it really requires our full focus and attention to how our patients appear to be responding to any types of activity we are doing with them and any assessments we have engaged in with them. Typically, if you require ICU care, it's because of respiratory failure or systemic shock, which may have advanced to multi-organ failure or may not. It typically results in a long length of stay for the ICU compared to what we've typically seen in the past from other illnesses. So 1 to 3 weeks in the ICU, and there are high rates, unfortunately, of ICU mortality. So when this disease does become severe, it really can be quite fatal. So COVID-19 best practice overviews. If you want more information regarding the pathophysiology of the disease, I don't really want to spend a lot of time going into that here because it's so easy to find it elsewhere. And the National Institute of Health, as you see on this slide, really has a very user-friendly, easy to reference quickly website now for people to look at that gives you much more information about the pathophysiology and some best practice guidelines in critical care. So COVID-19, I think the aspect of the disease that's best known is the cardiopulmonary aspects of the disease. It's really a lower respiratory tract hypoxemia. Lung compliance can be preserved, and there's a real dysregulation of pulmonary perfusion. There's a ventilation-perfusion mismatch and shunting. It's very much a disease of hypoxemia as opposed to other forms of pneumonia where we see the lung tissue itself become infected and filled with secretions and fluids. This is really more about an integral damage to the alveoli that happens through how the virus is entering the body. and there is some impact on the surfactant that maintains the alveoli open. So this is a lot to do with why the patients can have some very atypical presentations for their hypoxemia versus what we're traditionally used to seeing in various types of pneumonia. They can have apneic moments, they can have silent hypoxemia where they really don't notice, and they're in the community setting, that they are really compensating and ventilating a small portion of their lungs, and meanwhile their oxygen perfusion throughout their body is remarkably low. They can have some very sudden respiratory decompensations as a result. And acute respiratory distress syndrome is a prominent feature of severe COVID-19. There's also a cardiac component, so there can be cardiac myocarditis, myopericarditis. Again, that inflammatory immune response probably is partly at play here. Cardiomyopathies and arrhythmias, infections, coronary artery disease history of the patient, and demand on the cardiac system due to the hypoxemic lungs and the heart compensating for what the lungs aren't capable of doing, probably add a lot to why this happens in the patients. There's another element to the disease that creates some vascular microthromboembolic processes and possible disseminated intravascular coagulopathies. So there's great potential for one component of severe COVID-19 disease to be that there is a malfunction in the clotting process, or there are tiny emboli circulating in the vascular system, which leads us to some of the neuromuscular components of the disease. So coronaviruses are known to be capable of invading the central nervous system. And one thing that is interesting about some early research from China, from Wuhan, is that there's some autopsy evidence of people who died of COVID-19, that there is COVID present in some of the brain tissue samples of the autopsies. Patients with severe infections are more prone to neurologic symptoms. There has been some documentation of older patients' initial symptoms not being fever or cough, but rather being that their initial presentation is they end up having a stroke. And so there's clinical practice recommendations now that patients who are older and come into the emergency department, if you have the testing capability, you should test them for COVID-19. So, acute respiratory distress syndromes, we've heard a lot about this to the extent where you might think it is a diagnostic category in and of itself. And it really is a description of the integrity and the capability of the patient's lungs at the time of their disease presentation in the intensive care unit. So these are patients who have a diffuse presentation on their chest x-ray bilaterally of infiltrates, often the ground glass opacities, or a hazy diffuse sort of edema, pulmonary edema on their chest x-rays. There's a Berlin definition that talks about the ratio of the partial pressure of oxygen to the FiO2 that the patient is receiving, and if that is less than 300, that is what qualifies the patient as having acute respiratory distress syndrome. So it's typically the patients you see who do require mechanical ventilation, and depending on the level of acute respiratory distress syndrome that they have, will depend on what type and what type of mechanical ventilation they will need, and amount of sedation and other strategies such as proning. So what does proning do? Proning really is a recommendation for positioning of patients with severe ARDS. There is some evidence base that it can be a valuable tool to treat patients who are awake and not even necessarily on mechanical ventilation, but rather on high flow oxygen, to self-prone. And the reasons why these are good strategies for helping to improve oxygenation is it creates a more homogeneous aeration of the lungs. It really balances the ventral dorsal transpulmonary pressure gradient. So essentially what we're saying is that when you lie on your back, the pressure of your chest wall and your heart make it more difficult for you to be able to oxygenate the dorsal aspects of your lungs, where there is a larger lung surface area. So if the person is not lying on and compressing that aspect of the lungs, if instead they're lying on their stomach, it's much easier for them to aerate this larger dorsal area of lung and homogenize better what parts of the lung are receiving oxygenation, which also would help prevent damage, because then when you're adding mechanical ventilation to the system, you're able to breathe air or force air into not just one specific region of the lung, but more parts of it altogether. So there is recommendation, there's a clinical practice guideline from the American Thoracic Society that tells you which patients it's appropriate for. It's a strong recommendation for adult patients with severe ARDS combined with low tidal volume ventilation, and the prone positioning needs to happen for more than 12 hours per day. This clinical practice guideline recommendation, however, really is based on the results of one large study, the ProService study trial. And one thing that the clinical practice guidelines do ask you to consider is that the trial that recommendation is based on was conducted in a large center that the very well-trained practitioners in, and you would need to be able to reproduce that level of skill and competence in your facility to get the same results. The potential problems and concerns with prone positioning are obstructing the ET tube, kinking the tube, or creating skin breakdown on the front aspect of the patient. The other concern that they mention is this might limit how much early mobility that the patient is engaged in. All right, we also understand that one way that acute lung injury is prevented in patients requiring mechanical ventilation is a low tidal volume system of lung protective ventilation on the ventilator. And the reason I mention this in this slide is just to help you be familiar when you look at the ventilator with what it's doing and what it's set for. Low tidal volume ventilation tends to be very difficult for a patient to tolerate well. It protects their lung tissue from damage. However, because they have such a low tolerance for it, they typically also require sedation, and this is usually in the early phases of the severe ARDS. So again, the references for that come from the ARDS network, which was a large multi-center trial done to compare it to the previous standards of a higher tidal volume ventilation, where patients were ventilated at 8 to 10 liters instead of 6 to 8 liters. There was a robust protection of lung tissue and mortality benefit that came from this trial. So next I want to turn to the other important aspects of care for critically ill patients, and that's the ABCDEF bundle. This comes from the Society of Critical Care Medicine. They created clinical practice guidelines called the Pain, Agitation, and Delirium Guidelines in 2013. They updated those guidelines in 2018, and they are now referred to as the PAD-IS guidelines, pain, agitation, delirium, immobility, and sleep guidelines that the Society of Critical Care Medicine has presented for best practice. What the ABCDEF bundle is the ABCDEF bundle is the implementation strategies for those clinical practice guidelines. And here, these are the objectives of the ABCDEF bundle. And these are very important for physical therapists to be familiar with, because if we are going to mobilize these patients and help them out of bed while they are still in the intensive care unit, we really need the entire bundle to be implemented in order for us to succeed. So that has to start with spontaneous awakening trials. There's a safety screen, and there's some indication of if the combined with the spontaneous awakening trials as the spontaneous breathing trial. So what this is you're turning off the sedation for the patient in the trial, and you are at the same time going to switch the ventilator to pressure support ventilation and a lower settings to the point where the patient is essentially breathing on their own. So typically that would be 8/5 or less, a pressure support of 8, a PEEP of 5, an FiO2 of 0.4 or less. And what you want to demonstrate is, can the patient breathe sufficiently on their own to the point where you will consider extubating them. So it's important when you look in the room of your ICU patient to try to be able to know if they're on a spontaneous breathing trial, or if they're on a spontaneous awakening trial, or if they are potentially ready for one of those and one of those will be conducted. You don't want to mobilize the patient while they're in the middle of a spontaneous breathing trial. You need more vent support typically, especially if it's someone you haven't mobilized well previously. And so you need to coordinate with the nurse and the respiratory therapist to determine how you will time mobility in and around these interventions. So regarding our patients and the preventive aspect of them and thinking of them in the ICU with a disease like COVID-19, I think it's important for us to imagine what our patients go through and imagine waking up with your most primary abilities gone. You can't walk, you can't eat, you can't talk, and as far as you can tell, you are not able to breathe very well. It really is enough to induce delirium. And this is an article that gives great insight into the patient's point of view of delirium from their own experiences. It's really worth reading. In COVID-19, we know that because of the microvascular issues, the hypoxemia, the sedation, and the isolation, these all add significantly to the patient's susceptibility to delirium. And that delirium itself, when we look at how patients describe it, is it's a very perturbing, altered reality. They have a disturbed sense of time, disoriented sleep, very often hallucinations, a very disconnected, discordant identity, and isolation versus the human impact of connection is really something that adds to the surreal aspect of it for our patients. So we know that this is an assessment tool for how we determine if our patients are delirious or not. If you're unfamiliar with doing the CAM-ICU, I highly recommend that physical and occupational therapists perform a CAM-ICU on all of their patients. We really cannot determine if a patient is truly delirious or not without testing for it. You really can't just have a conversation or look at a patient and say they are or are not delirious. It's best to test for yourself, and I enjoy doing this test because sometimes I think a patient is delirious and then they do fine in the CAM-ICU, they're CAM-ICU negative, and it's quite the opposite. Sometimes I think this person's not delirious at all, they're fine. I walked in the room and they said hello and good morning and they greeted me and they made eye contact and they seemed very present, and yet you can do the CAM-ICU and it comes out positive. So it's a nice test to do, it's very quick, it's very easy to learn. If it isn't familiar to you, visit ICUdelirium.org, which is a wonderful website run by the folks at Vanderbilt University, and they have videos, they have instruction, they have these free little pocket cards that have the process on it for you to download. It's a great So these are some tips for improving the effectiveness of bedside delirium screening. We really want to understand what's happening with the patient's sedation. If they are CAM-ICU positive, what is their cognitive status? What is their target sedation, their target RAS versus their actual sedation, actual RAS? And we need this to be a conversation among all the practitioners at the bedside. So when you do have a delirious patient, the question then needs to become why, and is there a system of new organ failure, new infection? Have they been hypoxemic to the degree that they're in some versions of brain failure? Is it that they are sleep deprived? Do they simply need to have their hearing aids in or their eyeglasses on, or do they simply need to get up and move around? So it's really a call for us to recognize that the person is in an acute brain failure situation, and we should really try to determine what the sources and the cause of that brain failure are. We know that one of the best evidence-based treatments of delirium is mobility, and we know that immobility causes delirium, and they are a vicious cycle that play off of each other. It really is difficult to tell which comes first. The inability to move that creates the delirium, or the delirium creating the inability to move, they definitely coincide with each other. As much as you can prevent immobility, you can very likely help prevent delirium. As much as you can treat delirium with mobility, you can have further success at preventing more delirium. So we also understand that skeletal muscle is a vital organ system. So we need to get our patients moving. They need to have some strength to do it, and we will be encouraging and improving the use of their vital organ system known as skeletal muscle. Muscle is an endocrine tissue that influences all these other aspects of good physiologic homeostasis: capillary density, vascular angiogenesis, neuroplasticity, insulin resistance, inflammatory response. These are all regulated with the assistance of skeletal muscle. And we know what happens during an immune crisis, as with COVID-19, is that the body will shed skeletal muscle in an effort to save itself. Because your skeletal muscle really is your suit of armor. It is your guard against the invaders of the world, such as viruses. And the exuberant immune response will also mean there's going to be an exuberant catabolism of muscle, because catabolism of muscle is something that your body does to try to regulate the inflammatory responses and to try to invoke enough of an immune response against the disease. So we know that in the early aspects of having acute respiratory distress syndrome, that there is some pronounced muscle wasting for all those reasons. And if that goes on for too long, that can rather quickly turn into a profound overall weakness that is a change in the architecture of the whole muscle fiber. So muscle fiber sarcomeres start to break down in a way that really damages significantly the integrity of the muscles everywhere. It can, even if it goes on for weeks of immobility in the ICU, end up looking like a near quadriplegic type of overall global weakness. There's also going to be a loss of bone mineral density anytime you lose muscle, and a propensity to develop frailty. We also know that frailty is a leading indicator of someone going into ICU-acquired weakness. Again, what comes second? So, the 2018 pain, agitation, delirium, immobility, sleep guidelines from the Society of Critical Care Medicine has some recommendations regarding early mobility. And we recognize that early mobility is still a tremendous challenge, and that when we look at the different studies reporting on the intensity and the prevalence and the frequency of out-of-bed mobility for our patients in the intensive care unit, particularly if they have required mechanical ventilation, that the activity levels are still extraordinarily low. They still tend to be rather late and infrequent. And therefore, since this is the baseline that we're starting from, and now we're entering COVID-19, where it's going to be even ever more challenging between the severity of their acute respiratory distress syndrome, the levels of sedation they often require, some of the paralytic medications they require. Given all of this challenge, we understand that it's probably going to make ICU early mobility even more delayed and lower level of activity. My one comment about that is, do your best when your patients are ready to be awake and to perhaps be switched to a pressure support form of ventilation instead of an assist control form of ventilation. That's one clue that they also should really be able to get out of bed, if at all possible, or if nothing else, sit on the edge of the bed. So that's my guideline for that for now. And really how much we can do, or how much impact our initial diagnosis has on what treatment strategies we have for our patient, will depend a lot on where they're at in the course of their ICU stay. The way we tend to discuss and think about our patients is often by the admitting event or their diagnosis on admission. And when we're just talking about a stay in the intensive care unit, then we have to appreciate that after 1 to 2 weeks in the intensive care unit, that initial admitting diagnosis matters less to what the patient is going to be capable of doing, or your treatment decisions, or even how long they were going to need hospitalization, or what their eventual rehabilitative needs and or disabilities are going to be. Now depends a lot more on what did they bring with them in terms of resilience prior to getting sick. what comorbidities, what other medical burdens, what type of physiologic reserve in terms of their physical performance, their age, their physical activity histories, their level of skeletal muscle integrity. Because mobility is a vital sign, and we know that the flip side of mobility and having a vigorous skeletal muscle system and a vigorous cardiopulmonary system, that the flip side of that is frailty. And we know that frailty results in a greater propensity towards systemic inflammation, muscle wasting, sarcopenia. These are all aspects of frailty that make a diagnosis like COVID-19 more likely to convert to a severe form, or more likely to have the outcomes be not favorable. So these are all the aspects we need to look at in our patients when we're making our treatment decisions. And we know that this is definitely a team sport, that it requires collaboration across the disciplines in ways we haven't necessarily traditionally done. That I, as a physical therapist, don't mobilize my vented patients. I do it in collaboration with my nursing and respiratory therapy colleagues, but I also require the support and the physician orders to turn off the sedation, to set the ventilator in a way that we can support the work of breathing. At UCSF, we have developed some exclusion criteria. This is our safety screen for who we can mobilize and who we might need to wait until they recover more from their critical illness. One thing I encourage people to assess, because one of the greatest barriers to having your patients progress to out-of-bed mobility, particularly when they're on the ventilator and in the intensive care unit, is dyspnea. If you ask the patients, are you feeling like it's hard to breathe, very often even if their O2 sats on the monitor look good, they're feeling some sense of air hunger. And it's important to ask them directly, is that what is distressing you? You can gauge from what they're doing on the vent, from their facial expressions, and from how the monitor looks, what's happening with their breathing. And then you want to try to adjust their activity and adjust the ventilator or whatever other piece of oxygenating equipment they might be on, to reduce that sense of dyspnea, and then to allow them to be active and exercising with you. So strategies of how best to support the work of breathing. Remember that the breathing should not be the workout. That while it seems fairly normal to see someone in the intensive care unit struggling hard when they're very first setting up and learning to get used to and adapt to the feeling of an ET tube in their mouth, the breathing is not supposed to be the workout. They really should not take long to adapt to the sensation of the tube in their throat. If they are, what really needs to happen is you need to adjust the vent to allow for the activity to be engaged in comfortably by the patient. For us, very often that means we're increasing the pressure support a little bit on the ventilator and maybe the FiO2 a little bit. But these are all the things you have to work out at your individual institution in collaboration with your physician and respiratory therapy colleagues. I'd like to add that patients on various types of equipment in the ICU still can engage in mobility, and therefore restrictions on patients based on certain types of equipment, such as a continuous renal replacement therapy or CVVH dialysis, femoral catheters, mechanical ventilations, these are no longer considered barriers or exclusion criteria for early mobility. So, therapeutic alliance with our patient, and this picture obviously is in a non-COVID era when I really would incorporate my family members into my treatment strategies as much as I possibly could. So our patient in this photo, She has a severe form of meningitis and required neurosurgery, and she was on continuous renal replacement therapy, and she'd had a stroke, and she was on a ventilator, and she was septic, and she was in our ICU for 3 weeks. So we set a standard time with her husband, and he would come and we would sit her up and he would do the exercises with her, because one of the most important aspects of the care you provide as a physical therapist in the intensive care unit is that therapeutic alliance, is that sense of touch and healing you can bring to the patient. And so within the parameters of what we need to do to protect ourselves and our patients and our community with COVID-19 really makes the creation of this therapeutic alliance with the patient so challenging. I miss my family members so much. And here are the unique goals for physical and occupational therapy in the ICU setting. So this is a gentleman who's on ECMO and about to get on a treadmill in our cardiac ICU. It was an old picture. But we are very holistic and comprehensive in the way we need to view our ICU patients. So while we have pulmonary goals of really trying to help liberate our patients from the ventilator, we also have cognitive goals in our delirium prevention. We want to empower and prevent psychological harm to our patients by letting them get up and move under their own power. We really need to create individualized treatment programs, and it really helps us assess, is this patient recovering or are they really still struggling, and is something need to be changed in their care. Because mobility is a powerful medicine that helps so many things, and I have utilized this slide in my presentations for so many years, and I've done it simply because if you look at that list of things that mobility provides to our patients, if there were a pill that provided each one of those things, it would be considered the magic pill. And if you also look at that list, you probably can already think of certain medications that are utilized to try to mimic the good medicine that mobility is. So just a reminder and a summary of what the acute patient needs are for any of our patients that end up in a severe illness crisis. And going forward, again, looking at the type of inflammatory process and all the devastating catabolistic depletion that creates cognitively, physically, cardiopulmonary endurance-wise. And here's the types of things we as providers can do. We want the sedation turned off for our patients in the ICU, but when the sedation is turned off, we need to be right there at the bedside, talking them through what is really happening to them, talking them past that sense of disoriented self, that disconnect, the hallucinations, what all the uncomfortable tubes are that are stuck in them, the importance of those tubes, and support the work of breathing so they don't feel dyspneic. Assess their rates of perceived exertion, assess for delirium and for pain, all as you go along moving the patients. And if you can, progressing them to the point where they can be awake enough and strong and mobile enough to walk down your hall. And so this was a patient that wrote this note to me. After a couple of days, we saw her very early in her ARDS crisis, but she tolerated well sitting on the edge of the bed and standing up. The first day, she tolerated well getting to the chair and walking a little bit in her room. The second day, she tolerated a pretty good walk down the hall. And the third day, And on the fourth day, the nurse got her up out of bed to the chair, and she was sitting in the chair, and she hadn't seen me yet. She was worried that that's all it would be. And so she wrote this note to me on the clipboard and handed it to the nurse and asked the nurse to go show it to me wherever I was, because she really wanted to make sure she got her walk in for the day. This is not someone who was athletic. The people who seem to understand the value of mobility in the intensive care unit the most are the patients and family members. This type of a EVA support walker, you see our portable vent and our respiratory therapist is sort of hanging out in the back. But the EVA support walker, I can't say enough about how the EVA support walker with the oxygen tank holder in front of it is just a valuable life-saving investment for your intensive care unit. These are resources to provide to our family members to help explain to them some of what's happening to the patients and some of what aspects of staying in the ICU are, since they cannot be with us in the ICU during the isolation restrictions from COVID-19. Again, now we want to talk still about prevention in the prevention phase of this, but that's the hardest part, I think. Or at least it's the part we are most engaged in right now in this new pandemic situation. And provider well-being, because we can't take care of our patients if we aren't also taking care of ourselves, and understanding how to balance the amount of time we spend in the room, understanding how the room should be made safe for us, and the PPE should be safe for us as well. We should not feel like it's standing on the edge of a cliff just to stand in the doorway of our COVID-19 patients. From a community aspect, we understand the concept of trying to flatten the curve. What all that refers to really comes from epidemiology, particularly learning from the 1918 flu pandemic is enlightening. If you look at information from that pandemic, what you can see is two cities in the United States. One was St. Louis and one was Philadelphia. And St. Louis enacted very restrictive shelter-in-place, social distancing measures, and Philadelphia did not. And meanwhile, by implementing those, what you end up with is, rather than a deluge of cases, you end up with a slower stream of cases, and overall you end up with a lower death rate and a greater capability of your healthcare system to respond and manage the care for the patients. Because community prevention is just about minimizing transmission of COVID-19, understanding that it's because we cannot tell an infectious, contagious person from a non-infectious, non-contagious person, and therein lies the struggle. We don't have testing capacity yet, and so social isolation becomes our only option. What the WHO is recommending in terms of feeling like your testing capability as a country is adequate is that you'll be getting about a 10% positive rate for COVID-19. Typically in the United States right now, we're getting people that are doing testing. The various states tend to be getting a 20 to 25 positivity percentage rate, which means we are not finding enough cases to bring that positivity rate down to 10%, and so we haven't really enacted enough tests yet to be able to stop social isolating. What social isolating is about is not overwhelming the healthcare system and buying time until a vaccine is available. We need to be able to slow the number of cases as much as possible until the creation of a vaccine becomes a reality, because we really don't know what the extent of immunity is, even in people who have been treated for the illness and are now symptom-free. So moving on to the next phase of care, we talk about sustainability and consistency for our patients. Our patients will typically spend a long time in the hospital. The Italian Physical Medicine and Rehabilitation Society describes a trajectory for severe COVID patients of something like 3 weeks in the ICU, 3 weeks in the hospital, 3 weeks of required after acute rehab of some sort. We aren't seeing a trajectory as long as that in UCSF right now, but certainly it's not unreasonable to have these patients in the hospital for a month or more. And that's a long course that will require some sustainability of care. We know that the COVID-19 course can be really variable and also unpredictable. And so the best way to maintain good care through all of that is to just stick with the evidence-based strategies we know that work well in the ICU setting. That can be found in the ICU Liberation A2F bundle. So we know that the COVID-19 patients can be really difficult to oxygenate throughout the hospital course. Again, just another reminder to, even when the patient is out of the ICU or back on the floor, or if they're not on a ventilator, if they're on high flow oxygen perhaps, to please consider support the work of breathing, which usually means you need to give them added oxygen support, increased pressure support, or perhaps a non-rebreather instead of a nasal cannula that they're resting on, or perhaps if it's high flow, add a non-rebreather over top of the high flow while they are active. And think of allowing them really pretty substantial sustained rest periods between little bouts of activity because of their respiratory physiologic compromise. They really require a good recovery break between bouts of activity. Remember, mobility is also about connectedness, and the connectedness we want to sustain throughout the patient's course, because we also want to help address their emotional needs, and that these emotional needs are symbiotic with movement. And being out of bed, remember, helps to relieve patient suffering and fear and sense of powerlessness, anxiety, confusion, pain are all treated with mobility. So our patients are more focused and aware of the therapeutic alliance and the healing connection. When there are studies that are done to interview patients who receive rehabilitative care in an acute care setting, it's really that therapeutic alliance that they notice more than the actual exercises that have been done. So one thing to really consider is how challenging it is for our patients to transition from very direct and consistent care they might have received in the ICU to the floor, where they know they're going to have a lower patient-to-nurse ratio and probably a wider range of providers. Anytime physical or occupational therapy can be a consistent provider amidst all of that and help our patients through their transitions, I think it's very valuable to the overall patient. And again, as they go to the floor, as they're able to tolerate greater levels of activity, we want to think about applying our exercise training principles. We don't want to just rely upon functional assessments, functional goals, discharge planning as the sum total of our treatment, particularly for these COVID-19 patients who we really need to provide with some comprehensive rebuilding of all that broken down muscle and limited endurance, low cardiopulmonary status. And so you really want to put on a bit of your acute rehab therapist hat, your outpatient hat, and come up with some specified, individualized exercise programs for patients, particularly to help them recover and return home we know that skilled nursing facilities and acute rehabs may not be much of an option for them. And that will be very much based on who they are and who they've been. And so I referenced the photograph on this slide because if you were to look at this woman and she were just lying in your bed with in the hospital bed with the covers pulled up over her chin, you could assume she has a certain level of frailty or incapacity based on her age. And yet, when you find out who she's really been, she's a marathon runner, and therefore we can come up with an exercise prescription for her that might be entirely different now that we know more of what she's brought in her fitness bank account to the experience. So again, we have to remember concepts of physiology in creating the treatment strategies for everything we do with our patients, regardless of the setting we find them in. We want to avoid the maladaptions that are created by our patients spending anywhere from 20 to 23 and a half hours a day lying in bed and thinking that gravity no longer applies to them, that horizontal is normal. That's a maladaptation that their body has created based on the environment we've put it in. Understand that to treat a falls risk with immobility is really increasing their falls risk. We need to be more creative and more mobile and more exercise oriented to really help, particularly the COVID-19 patients in the hospital setting. We also think that there's some great literature to draw upon. While there's not much specific to COVID-19 rehabilitative strategies or anabolic muscle building strategies in these patient populations, we know that the geriatric and oncology and even the endurance athlete populations can give us some good basic physiologic principles to draw upon to make our exercise prescriptions. And again, this is quite a marathon for our patients and for our providers as well. We need to be able to monitor progress and motivate our patients, and that's where sustainability and consistency really come in, because it is being the person who knows how the patient looks from day to day that can be very helpful. I think it can also be really helpful for us if we are able to be a consistent provider for the patient day to day. We can become a designated communicator with the family, and the family knows us and knows who we are well. We can also draw from aspects of things the family provides to help decorate the room, to bring more personal comfort items into the patient's room. We often Zoom our video into the computer inside a patient's room so that the family can be on the screen motivating and interacting with the patients while they're engaging in physical therapy. And one of the best ways to provide that psychosocial support, but also receive it in a way that helps you sustain your practice, is to try to be able to be a consistent or primary provider for some of our more long-term COVID-19 patients. We all run the marathon together, patient and provider alike. I think it's also important in terms of understanding the community implications of sustaining and consistently knowing what we have to work on, is to realize how there's such a disproportionate share of severe COVID-19 deaths and cases among what we consider minority populations in the United States. African Americans and Latinx people are going to be hit harder by this disease, and therefore they will require extra attention on our part. and they might require educational materials that speak to them in their language. So when you are developing those materials, consider your patient populations and consider making those materials culturally inviting and culturally understandable and language understandable to everyone you might treat. So some tips to think about for you and your nursing staff in terms of things to review with the patients. Thanks to Jackie Washina posting this on Twitter for knowing how to help us make sure our patients are prepared to discharge the hospital when they have COVID-19. And understanding that there's going to be significant post-ICU debility as a result of this disease process. We'll have to educate our family members, we'll have to educate our patients, but we'll also have to really work hard in running that marathon with our patients and family members to try to reduce this prevalence, because we do not have good post-hospital stay rehab offerings for our patients in this particular pandemic moment. So one of the most striking aspects of after acute respiratory distress syndrome is the profound fatigue our patients feel. We also know that fatigue is a prevalent symptom among cancer survivors. So again, there's probably a lot in the oncology world and that we can draw upon in treating COVID-19 patients and considering what some of the long-term needs of our COVID-19 patients are. So in creating resilience in those patients, we're going to be looking at the mental, physical, spiritual, and emotional side of this person. And we're going to be developing educational messaging for them and their family through telehealth, through Zoom, through PowerPoint presentations, through handouts, through YouTube, however we can do it, and we probably need to do it with all of the above on all the various aspects of what now is really going to, once the patients leave the hospital, in order for them to not return to the hospital and to be resilient human beings in their home setting where they're most likely going to need to be as a result of COVID-19. Avoiding falls, managing the fatigue and the dyspnea, the strength training to rebuild the muscle after all that muscle breakdown will be essential. We need to help them have a restored sense of connection and purpose with the larger world, and that we can let them know anxiety, it is a normal human emotion. It's when we react to the anxiety with less than acceptance, but instead fear, that the fear is really a maladaptive reaction. And so anxiety needs to be a managed psychological component of what we try to address with the patients. Obviously, sleep, nutrition, and bringing the whole person back together into one formed, clear self. For our providers and our community, in terms of creating resilience, we need to be able to share in our experiences. And I think one of the things that helps me feel most resilient in treating ICU patients in general, but particularly the COVID-19 patients, is to have gratitude for the community of providers and the care that they've shown to our patients and families and to each other, and the interconnectedness of all of us. There's some references there for the Pandemic Kindness Project, and CODA is a podcast regarding some of the more psychosocial aspects and community aspects of working in the intensive care setting. We know how to do this, we really do. It's extraordinarily challenging, but one thing I am seeing is really beyond my expectations. Our patients are recovering, and our patients are able to get stronger, and our patients are able to bring themselves back to the life they knew before, and to be at home and to be functioning parts of society. When we just treat the whole person and do our best to maintain the integrity and resilience of that entire person there with us in our hospital. It can be done with COVID-19. Again, for our patients, I think the cancer exercise guidelines and some exercise prescription information from the oncology community, who has been really treating a lot of the same disabling effects of disease and treatment that occur in our COVID-19 patient population, but they've been doing it a lot longer. I don't think we have to reinvent the wheel for COVID-19. I think we can draw upon and look at this recommendations from the American College of Sports Medicine and the cancer survivorship exercise programs and all the extraordinary programs that various cancer organizations have created to help us determine what we can do to help our patients really restore their lives, particularly after they're returning home. How to help them move past the trauma of the hospital stay and restore the life that they knew. So when we're creating, again, when we're thinking more in terms of exercise dosage and aerobic capacity, these are just some guidelines that I have used for quite a while with the cancer patient population. And it's just important for folks to understand that they are going to leave the hospital with having survived a COVID-19 severe diagnosis, or even being at home recovering from a mild to moderate diagnosis, with a lowered aerobic capacity. The good news about a lowered aerobic capacity as a result of illness is that exercise training works, and this cancer study is a really nice example of how someone can start with an incredibly impaired aerobic capacity as a result of a cancer diagnosis. But again, I think this will apply to our COVID-19 patients in a very similar way. But that with a consistent 10-week aerobic exercise program, you can restore a lot of your aerobic capacity. So just to give folks some understanding of the metabolic equivalents of various activities, I often try to teach people how stair climbing is really 5 times as much aerobic capacity requirement as just walking on a simple, smooth, flat, level surface. And that needs to be taken into account in terms of relative to how energetic and how much endurance you feel the patient feels like they have. So again, just some more tips on what aerobic exercise dosage can be based on for various activities and what kind of capacity it requires, and therefore how distressing that activity is or how maximal an effort it would require. But none of that matters if we can't motivate people, particularly if they have had a sedentary background, and now we're really needing to ask them to exercise as a new behavioral intervention to restore their body and restore their lives. So some motivating behavioral change tips we can offer our patients. And again, the Society of Integrative Oncology has some nice recommendations for integrative medicine practices to help with things such as coping and anxiety and restoration of your psychological health. Society of Critical Care Medicine Thrive campaign has information at myicucare.org regarding post-intensive care syndrome. And there are some broader resources because COVID-19 will definitely be a test of the resilience and restorative capability of our patients, providers, and our community at large. And so again, particularly in terms of educating our patients and families, we need to look at a broader scope of interventions and offerings than we have in the past. So when might some of our current shelter in place end? At what point will we be a restorative community again? And just to give some insights into how these transitions would most safely occur, I'm listing what the governor of the state of California and the CDC have offered in terms of recommendations for how we gently transition out of shelter in place and isolation towards a little bit broader society. We can't suddenly go back to business as usual. It will cause a surge and another wave of high numbers of cases suddenly occurring. And we know that, again, from the history and epidemiology of other epidemic experiences. So, in order to not have a surge of cases all over again, the testing capacity and contact tracing really need to increase. We need to have the best preventative measures we can come up with, and we have to have a resilient health system. We're also probably in the fall, businesses and schools are going to need to be able to carry out some version of social distancing still, so we don't have a major resurgence in the fall. And if there are major resurgences, we have to, as a community, however broad you want to take that, be able to agree that it will be okay to reinstate stay-at-home orders all over again. So again, looking at the restorative capability of all of us, it's going to be about reflection, not rumination, and refocusing ourselves through the peaks and valleys of surges of cases and plateaus in the curve of numbers of cases. How to manage the moral distress of what your standards of providing practice are versus what your healthcare system situation might allow for. An overwhelmed healthcare system is going to be morally distressing to anyone who has to work within it and to anyone who has to be a patient within it. And so I feel protecting our healthcare systems and making those as restorative and resilient as possible is going to be an important public health consideration. We have so much long-term socioeconomic reverberation to think about. Tracing and quarantine acceptability needs to be adapted publicly. And local resources, we need to be able to know about them so that we can engage in them ourselves, and so that we can inform our families and patients what is available to them. So here are some resources for us as providers for continued updates and just general knowledge in terms of understanding COVID-19 in the public health realm and what it means for us to be in a pandemic treating people with this public health problem. And then my final slide is just to say I'm hoping that one day we will be able to restore what we provide to our patients with severe illnesses requiring ICU care to something that looks like this, where our patients will be awake, out of bed, not delirious, glasses on, pet dog in their lap, and a family right there next to them. That's how we were, and it would be lovely to be able to get back there again for the health of all of us.